I am Varun Puri. I am a professor of surgery at the Washington University in St. Louis and a practicing thoracic surgeon and health services researcher. Smoking, which is highly prevalent in the lung cancer population, has a significant impact on both short and long-term outcomes after treatment for lung cancer. And in the next few minutes, we will learn about both the impact of smoking and the relationship smoking has on short and long-term treatment-related outcomes in patients with lung cancer, mostly early stage lung cancer. First, let's tackle how smoking is associated with short-term outcomes after surgical resection. As we know, coming into surgery, between 80 and 90% of patients who undergo surgery for lung cancer are either current smokers or have been smokers in the past. And when you look at different series, the proportion of current smokers versus former smokers varies to some degree. For example, in our current Veterans Health Administration population that our group is studying, the prevalence of current smoking in that population is upwards of 50%, which is a relatively high number. However, when one looks at, say, case series from large institutions such as cancer centers, the prevalence of current ongoing smoking is lower than 20 or 30% in these case series, with the majority of patients either former smokers or recent quitters. It's important to understand the relationship between short-term outcomes after surgery and smoking, simply because that relationship is quite strong. About 2 decades ago, the Society of Thoracic Surgeons established a general thoracic surgical database. This database collects information on short-term outcomes after major operations, particularly including operations for early stage lung cancer. A large analysis from this data set conducted by one of my colleagues convincingly showed that smoking is associated with extremely elevated risks of short-term post-operative complications, particularly pulmonary complications, as well as infectious complications. Since that landmark study in the late 2000s, there have been numerous large database studies, as well as individual institution studies that have shown that relationship and cemented that relationship between major post-operative complications and surgery for lung cancer. A recent Japanese study looked at about 80,000 patients, and they looked at 30-day mortality and the likelihood of smoking. So they saw that patients who were light smokers were associated with an odds ratio of 1.76 for postoperative mortality compared to patients who were non-smokers. The odds ratio for postoperative mortality was similar for moderate and heavy smokers. So there was really not a dose-response relationship in terms of postoperative mortality. However, when they looked at the likelihood of postoperative pulmonary complications as well as infectious complications, they saw a dose relationship. They saw that light smokers had an odds ratio of 1.2, moderate smokers 1.4, and heavy smokers an odds ratio of 1.7. So there was a progressive increase. And how to interpret these odds ratios is that 1.2 means a 20% increase in the likelihood of complications that are being assessed. And a 1.72 odds ratio means a 72% increase in likelihood of complications that are being assessed. Additionally, there are certain specific postoperative complications that are strongly associated with smoking. And this is independent of the degree of emphysema in the lungs or independent of the degree of decline in pulmonary function such as DLCO and FEV1. One of these is what's called prolonged air leak. An air leak is a postoperative complication which tells us that the staple lines that have been placed on the lung are leaking air, and the patient requires a chest tube to evacuate that air in the postoperative period. Most instances, you expect early postoperative air leaks to settle within the first 1 to 3 days after resection. If, and depending upon which data set or definition you're using, if you have an air leak longer than either 5 or 7 days after surgery, that is classified as a prolonged air leak. The implications of that being that the patients need to have a chest tube in place and either required to be in the hospital or are discharged home with a chest tube, which is subsequently removed at a postoperative visit. And this postoperative complication is specifically associated with smoking in the preoperative and perioperative period. Smoking is not only related to perioperative adverse outcomes after surgical resection, but is associated with adverse events after other forms of treatment for lung cancer. If one assesses stereotactic radiation therapy, which is an up and coming treatment for lung cancer established over the last decades, with increasing number of early stage lung cancer patients being treated with stereotactic radiation, the two most prominent either chest or pulmonary complications include chest wall pain / rift fractures or other chest wall complications. Early studies show a possible mild to moderate association in between chest wall complications after stereotactic radiation therapy and smoking in the patient population undergoing stereotactic radiation therapy. On the other hand, the importance of long-term complications or long-term adverse outcomes in patients undergoing stereotactic radiation therapy cannot be understated. If one looks at cohorts of patients who undergo stereotactic radiation therapy and assesses their long-term survival, there is convincing evidence to show that the long-term overall survival is significantly diminished in patients who continue to smoke in the peri-treatment and post-treatment periods. Smoking is also associated with adverse outcomes as well as unpredictability of treatment response in patients who are undergoing immunotherapy or chemotherapy for early stage or advanced stage lung cancer. There is a class of enzymes called the CYPP450 family of isozymes. These enzymes are intimately involved in drug metabolism as well as nicotine metabolism, as well as metabolism of many of the other agents that are in cigarette smoke. These may be particulate or non-particulate agents. And in patients who are smokers, there is a significantly higher degree of differences in metabolism of chemotherapeutic drugs in patients who continue to smoke as they're being administered chemotherapy. So this makes the availability or bioavailability of some of these drugs unpredictable. And although studies are ongoing, it is likely that we'll have greater information on the actual impact of smoking on the lack of efficacy of some of these drugs as they're being administered for chemotherapy. Two of the most important parameters in assessing long-term outcomes for patients with either early or advanced stage lung cancer are overall survival and disease-free survival. There is evidence which is consistent across all modalities of therapy, which looking at long-term survival, that smoking in the pre-treatment period as well as continued smoking in the post-treatment period is associated with a significant decline in overall survival in these individuals. Importantly, not only is overall survival reduced, the quality of life is also significantly reduced in these patients who continue to smoke after surgical resection or chemoradiation therapy for lung cancer. This lack of efficacy of treatment or disease recurrence or diminished overall survival is consistent across all age groups, races, and genders. Additionally, it's not only for non-small cell lung cancer that we see this relationship. A large study from Canada studied this relationship prospectively and saw that for patients with small cell lung cancer with limited disease, there was a significant decline in 1 year survival in patients who continue to smoke in the peri-treatment period. Additionally, there are certain subgroups of patients in whom the impact of smoking and its decline of overall survival and disease-free survival is even more pronounced. Particularly in patients who have metastatic disease to the brain either at presentation or develop metastatic disease to the brain after presentation, the likelihood of diminished overall survival and progression or disease-free survival is much greater in patients who continue to smoke. In addition, there are many prospective as well as retrospective studies which look at the effect of continued smoking after treatment. And they have noticed that there is a significant dose response association of the degree of smoking in the post-treatment period with the decline in overall survival, as well as diminished quality of life in the long term after treatments for lung cancer.